So yesterday I made a presentation on the treatment of HER2 positive early breast cancer patients. These patients have now a relatively good prognosis because of availability of trastuzumab, an anti-HER2 antibody given concomitantly with chemotherapy. We do have now new anti-HER2 treatments which can be added to trastuzumab. So the question is, when is it necessary to increase the burden of the treatment for those patients who are still at high risk of relapse? And is it possible to decrease, on the other side, the burden of treatment for those patients who still have a very good chance of being cured with available therapies? So my talk was focused specifically on two trials which have shown that addition of two other anti-HER2 treatments, either neratinib, a tyrosine kinase inhibitor, or pertuzumab, another anti-HER2 monoclonal antibody. And both these trials have shown that there is a statistically significant improvement in disease-free survival in comparison to the classic treatment consisting of trastuzumab for 1 year plus chemotherapy. But unfortunately, in both trials, the percent of the patients who actually benefited from the addition of a new anti-HER2 treatment was relatively low. So you treat a lot of patients to benefit a few, and of course you induce additional toxicities, especially diarrhea with neratinib, and at a less extent also with pertuzumab, and even a slightly more increased incidence of cardiac events. So it will be necessary to define more precisely who are the patients who actually need more. And we do have data to identify these patients. From the neratinib trial, it is clear that the patients with an hormone receptor positive tumor benefited more by the addition of neratinib in comparison to those patients with hormone receptor negative disease. So the first message is patients with high tumor burden, not positive disease, and hormone receptor positive disease might be considered for additional treatment with neratinib in addition to trastuzumab and chemotherapy. From affinity trial also we do have some data indicating that the patients with again not positive disease and on the opposite, those with hormone receptor negative disease might derive a greater benefit from the addition of pertuzumab. So here again can define a patient population, those with not positive disease and those with hormone receptor negative disease, where the addition of pertuzumab might be of value. On the other side, we do know that fortunately the vast majority of these patients nowadays are cured by chemo and trastuzumab given for 1 year, and we also know that unfortunately a proportion of these patients might experience unpleasant side effects, particularly cardiac toxicity. So is it possible for at least some of these patients to reduce the burden of treatment? There are trials which have explored the possibility to reduce the chemotherapy burden by avoiding especially anthracyclines, which are the most toxic component of the chemotherapy regimens. And this trial do demonstrate that it is possible to avoid anthracycline and still maintaining a very good disease-free survival by giving a non-anthracycline containing chemotherapy regimen plus 1 year trastuzumab. There are also trials which have explored the possibility to reduce the duration of exposure to trastuzumab by giving trastuzumab either for 6 months instead of a classic 1 year administration, or even shorter treatment periods such as 9 weeks. There are 5 randomized trials, relatively large randomized trials. Of course, these trials have been designed as a non-inferiority trials, and it's highly difficult to demonstrate non-inferiority. And in fact, 4 out of the 5 trials have not been able to demonstrate a non-inferiority with shorter trastuzumab administration versus 1 year trastuzumab. Only one trial, a trial from UK, the Persephone trial, comparing 6 months versus 1 year trastuzumab, has been able to show statistically that 6 months is not inferior to 1 year. But overall, all these trials have clearly shown that there are subgroups of the patients with a lower risk of relapse, which means patients with a smaller tumor size and no negativity, where there is essentially no difference at all by giving 1 year or shorter treatment durations. And on the other side, there is a significant reduction in the risk of cardiac events. So the key message is that we now know that for low-risk patients, if there are some cardiac risk factor, either baseline or during the administration of trastuzumab, you can safely stop the administration of trastuzumab without compromising the efficacy of the treatment. And this message is also important for those patients living in countries with limited resources. There are a lot of patients, unfortunately, worldwide who do not have access to trastuzumab because of financial constraints. So for these patients, it's a good message, the fact that you can give a shorter, so cheaper trastuzumab administration with still very good clinical results.